Welcome to this ESE talk nurse webinar, the topic of the day being osteoporosis. Before starting, I would just like you all to be aware of to save your questions until the we will go through questions in the end of the session. So if you have any questions during the presentations, feel free to use the question and answer box in the bottom part of the Zoom window. We will have approximately 1.5 hours today, and we have two sessions, two topics. Also be aware of this session is being recorded, and it will be available on the website as soon as possible after the session has concluded. So this is one of the nurse webinar that the nurse board of the European Society of Endocrinology has prepared for us. And the aim is to provide a virtual educational platform to support endocrine nurses' ongoing professional development with focus on developing nurses' knowledge and clinical skills in endocrinology. And we would also like to highlight the competency framework now being translated into 6 languages. And one of the subjects in the competency framework is osteoporosis, the focus of the day. And this is the schedule for today. And the first presenter is, actually we have 2 more minutes until we will start, but perhaps we can start a little bit early. So it's Professor Maria Luisa Brandi. She's a professor in endocrinology at the University of San Raffaele in Milan, and her field is bone metabolism. She's a member of European Society of Endocrinology, and she's in the board of the National Osteoporosis Foundation.
Good afternoon, everyone, or good evening, everyone. I'm here today very pleased to be part of this ESE initiative. Nurses are really central to the work that we are doing in the clinical area. But for osteoporosis, they are going to be more and more central in the future, what's happening in the world that I will show you today. So, and I hope with this presentation where I try to put a number of things that are of interest for nurses, you will just switch on even more the interest towards osteoporosis. And these are my disclosures. And when we talk about osteoporosis, we have to remember that we have these numbers. 500 million people affected, more women than men, as we can expect, but men are increasing because they are more diagnosed at this point. And certainly we have to think about that there are 37 million of people aged over 55 that are suffering for fragility fractures. Osteoporosis is just a condition that is the risk factor, one of the risk factors for fragility fractures. We have 70 fractures per minute. At the time we are going to sit here today, imagine how many people are fracturing around the world. But there is not one osteoporosis. As I will show you today, there are several osteoporosis and several bone fragilities. And that is what we need to learn in order to not simplify too much an area that needs attention, culture, and knowledge. The definition of osteoporosis was made 25 years ago when the World Health Organization decided to assign scores, numbers, that would define the condition of normality, osteopenia, and osteoporosis, and stabilize osteoporosis, where up to -1, we are normal. Up from -1 to -2.5, we are osteopenic. The osteoporotic person is -2.5, and -2.5 plus a fragility fracture, we, in this case, define the osteoporosis as stabilized or severe. Severe osteoporosis is an area of interest because many pharmacological conditions are supported either by the medical systems or by insurances, only if you are severe enough to be treated. So for us, severe osteoporosis is a definition important. Years ago, an Italian group defined the osteoporosis as severe if you have a T-score of minus 2.5, what defines osteoporosis in general, plus the presence of a prevalent fragility fracture. But even if you have two prevalent fragility fractures, not even having osteoporosis, but being normal osteopenic, you are severely affected. So we have to remember that it's the fragility fracture that defines fragility. And for us, fragility fractures, what happens either spontaneously or because we are dropping on the floor, for instance, from standing position or from a sitting position. That defines the fragility. Orthopedic surgeons know very well what is fragility in this sense. We have also in osteoporosis the possibility to monitor through bone biomarkers the actual metabolism of that person in that moment. For instance, a postmenopausal woman after menopause will have what we call a high bone turnover because the bone is maintained through a metabolism, and here the interest from the endocrinologist, a metabolism that is composed by formation and resorption, and that happens continuously in our body. So the condition of osteoporosis can be monitored through the definition of the bone mineral density through the T-score and the DEXA machines, but we can also use bone biomarkers to see if that person, that given moment, has a high bone turnover, where both resorption and formation are increasing, or a low bone turnover. And for us, this is very important because the treatment depends on the actual metabolism of that person, like having a picture of the past or a picture of that given moment. So we have markers that could be either in the urines or the serum that we can use to look at bone formation and bone resorption. Moreover, osteoporosis are defined also as secondary when there is a cause for osteoporosis. In general, we consider involutional osteoporosis the more frequent condition that is composed by postmenopausal and senile osteoporosis. Senile osteoporosis touches any individual that becomes old enough to be osteoporotic. However, there are conditions that can make us osteoporotic even in the young age. Even children can be osteoporotic. And these are conditions that cause loss of bone, either decreasing the formation or increasing the resorption of bone. And this happens in many clinical conditions. Many of the endocrine disorders are followed by osteoporosis: hyperparathyroidism, hyperfunction of the thyroid, hyperfunction of the cortical adrenal, or hypofunction of the gonads. So endocrine conditions control and the hormones control bone metabolism. Then there are conditions like hematological disorders where we can think about myeloma or cancer, because we are treating patients with drugs that affect bone metabolism, or malabsorption conditions, or neurological disorders like epilepsy, where we can treat patients with drugs that are decreasing the metabolism of vitamin D at the liver level. Then there are a very large number of genetic disorders. Remember that the so-called bone inherited disorders are over 500. So this is a very large chapter for which endocrinologists have a great interest. I just show you an example of a rare condition that is osteoporosis in pregnancy and lactation, with the following fragility fracture that fortunately rarely enough, but some women are suffering for. And that's a rare condition that is associated to lactation, to the delivery moment, and sometimes these women could be actually diagnosed in advance just because we know that they are at risk. But this so rarely happens because pregnant women are not evaluated for their bone fragility. Today, for instance, in Italy, we set up in the gynecological department ultrasound machine that can measure density at the femoral level. And this is a radiation-free method that allows not only the diagnosis of osteoporosis in the first trimester, but also the follow-up of the patient throughout their pregnancy. Today, we have also algorithms that can be used in this, for instance, nurses can become very important because you can apply risk factors questionnaires, you can give recommendations stem on nutrition, ensuring the vitamin D administration if needed, introducing the patient to genetic tests, and following up also through ultrasound machines that you can easily learn to use. The takeaway is that pregnancy and lactation are conditions where we can have a number of risks that needs to be actually evaluated at the beginning of pregnancy. And this is something that in these days starts to become of great interest for gynecologists, at least in our country, but I know that actions are also in place in the UK, for instance, in Germany. And the diagnosis can take advantage of an ultrasound measurement that can be used versus the DEXA machine that are radiological and we couldn't use at the beginning or during pregnancy. And then we can use drugs in these patients after pregnancy, and we can make recommendations like not having a normal delivery, but using the C-section if women are too fragile, because sometimes they fracture during the delivery, or reducing the time of lactation, because during lactation they tend to lose bone mass. So it's an area that is so important that we need to care, and this is a secondary condition of osteoporosis. Then we have conditions of osteoporosis where we have acute or rapid severe bone loss, like in glucocorticoid-treated patients, post-transplant, immobilization, patients that are immobilized so long after stroke, burns, low gravity, heparin therapy, anorexia nervosa, or surgery because of obesity. And we need to be aware of this because these people need to be taken care for their bones. Otherwise, they will go over the disease that brought them to the emergency room, but they will be fractured and their life will be miserable for the remaining part of the years they have to live. There are conditions that are rare, like for instance, the pregnancy that I just mentioned, genetic disorders, acquired GH deficiency, or mastocytosis, for instance, or conditions that need to be diagnosed and they cause osteoporosis. And there are an innumerable number of drugs that can cause osteoporosis, just to mention glucocorticoids, but also treatment that we use in mammary cancer and prostate cancer, where we use hormonal therapy that induce osteoporosis and fracture in such a very fragile section of the population. And we need to be aware because we can prevent fractures. Fractures can be prevented. That is something that needs to be well understood by everyone. Then we have patients that, for instance, develop an imminent risk of fracture. So they have a risk of fracture that is so high that in the next 2 years, they are going to refracture. They fracture once and then now refracture. And this happens to be very quickly in the elderly population, could be even in the 6 months after the first fracture. And these are the so-called imminent fracture people, something that we have to understand that is not linear during time, but they really need to be recognized. And people that, for instance, have been fractured already once for fragility, or they take or they take corticosteroids, their vision is not wonderful and they tend to follow very frequently. So if we put together all these risk factors, we build up the case of the imminent fracture. In these patients, we need to use drugs that are acting very quickly because we need to prevent the fracture by 6 months from the first fracture. And here we have the 10-year probability of major osteoporotic fracture to the FRAX risk score card. FRAX, that is FRAX, you can find in the web, is easily consultable, applicable, and sometimes today you can find even within the DEXA machine. And it tells you which one is the risk of a given person to fracture in 10 years in the major sites that we consider at least for fragility fractures. Needless to say, obviously the wrist, the vertebral bodies, the hip, but also the tibia and the humerus that are other part of our body that can obviously fracture for fragility. Then we have an intervention threshold that is recognized by the different agencies in Italy and in other countries in Europe, where we are told these patients need to be treated because they are in the red area, and we need to get these patients outside of that area. Most of all, we need to have these patients not fractured. And so in this way, we can categorize the patients in low risk, high risk, very high risk. And then the agency will tell us, yes, high risk, I can give you these drugs. They will be reimbursed. Very high risk, you can take everything because I don't want these patients fracturing because they cost too much to the whole society. And these are the drugs that we have available for osteoporosis. The majority are part of the so-called bisphosphonate bisphosphonate molecules, a large family. We have oral drugs that can be taken orally or intravenously, or we have another family of anti-resorptives that they reduce also, like aminobisphosphonate resorption, that are part of the estrogen or SERM, selective estrogen receptor modulator families, like the hormonal replacement therapy, raloxifene and basedoxifene. Then we have a very important anti-resorptive that is the antibody denosumab. And then we have anabolic agents like teriparatide, abaloparatide, and romosozumab. So a very large armamentarium that the clinician and the nurse, obviously in the future, can have in front of them in order to have the possibility to administer the best drug that the patient eventually does not abandon, because for us, the continuity of care is so important. All these drugs prevent fracture, otherwise they are not recognized as drugs for osteoporosis. And they prevent all of them vertebral fractures. Some of them prevent also hip fracture. The osteoanabolic agents are centrally quite interesting. If we look what happens when I use an anti-resorptive, in this case, let's say an alendronate, an aminobisphosphonate. The alendronate is going to decrease resorption, but in time is going to decrease also formation. And so we have to be aware about this. And that's the reason for which we don't tend to use drugs, but not forever the same. The anabolics instead tend to increase formation much more than what happens with the decrease of resorption of anti-resorptive. But in time, they will increase also resorption because the system of resorption and formation is coupled in bone. So these drugs, then we have to be careful not to use the same drug forever. If we look at the anabolics, we have 3 agents I just mentioned before: teriparatide, abaloparatide, and romosozumab. Teriparatide and abaloparatide act as pure anabolics. You see, they increase formation, in time resorption. A difference exists between abaloparatide and teriparatide because abaloparatide tends to be a less inducer of resorption in time versus teriparatide. There is, however, another anabolic that is called romosozumab. This is a monoclonal antibody that is actually acting uncoupling the system. So in this case, the drug is increasing formation and decreasing resorption. So in this case, we have a real bone builder, very strong drug that we can administer for 1 year. All these drugs have side effects. So we need to know those of bisphosphonates and denosumab and SERM, because, for instance, osteonecrosis of the jaw was causing cause in these antiresorptives, or SERMs like raloxifene can induce thromboembolism, and we have to exclude patients that are at risk for such. Teriparatide and abaloparatide can induce hypercalcemia, and romosozumab can induce cardiovascular complications. So therefore, when we choose an anabolic, we tend to choose the anabolic that is the cost affordable, convenient, eventually is covered by the insurance, and if adverse events are not contraindicated for the given individual. And we want, first of all, to have an idea on how long this drug is going to be used. And so for the 3 anabolics I just mentioned, you see that there are differences among them. And we want to choose the drug that is the best for our patients. So indication is certainly postmenopausal osteoporosis. So always, even though for teriparatide, we can use today also for male osteoporosis and GIO. And when we compare one anabolic to the other, in this case, romosozumab versus teriparatide, romosozumab appeared to be stronger. Or abaloparatide versus teriparatide, again, looking at bone density, there is a stronger effect of abalo versus teriparatide. And these are the fractures that have been counted. In this case, teriparatide versus abaloparatide, or residronate versus teriparatide, there is a potency that translates from bone mineral density to fracture risk. And these drugs, as I said, have also side effects. So we want to keep in mind the side effects, because if I have a cardiopathic person, I'm not going to prescribe romosozumab because of the cardiovascular implication. And if I have a cancer patient, I'm not going to use teriparatide and abaloparatide unless the patient was free of cancer for 5 years. And then we can use these drugs in a very smart manner, because actually having drugs that have different mechanisms of action, we can either associate these drugs, things that we do when we are desperate and the patient continues to fracture if we give one only drug, or we can use anabolics before antiresorptives, because that's the best way to attain the greatest results. So eventually I can use an anabolic like romosozumab for 1 year, and then to use an antiresorptive like alendronate or denosumab the remaining time for this patient. So as you see today, there is the idea of sequential treatment because this is more effective. When we use in combination is when I told you we are really desperate, we don't know what to do. Otherwise, the sequence is what we tend to use mostly. Combination of romosozumab with an antiresorptive is not recognized at these days. There are a few reports now that are coming out, but probably that wouldn't be the way that I would use romosozumab, that is very powered by itself. Certainly, we want to use the osteoanabolic before the antiresorptive. That's the smartest way, because it's like preparing the area to the antiresorptive, because we said that anabolics, pure anabolics like teriparatide or abaloparatide, increase formation, but then they increase resorption. And the best effect of an antiresorptive is when we give to a patient that has a high resorption. So that's the reason for which we believe that that's the best way to treat the patients. And certainly we want to use the anabolics in the very high risk patients, not in everyone. Sometimes we use also auto indication, like it happens today to pregnant women after delivery, because in that case we use anabolics that we prefer towards anti-resortives. That is not, actually doesn't have this indication, is out of the indication, but we need to use drugs also in these patients. We need really we need to be very creative, and the industry usually tends to be very creative, because at the end, what happens today? That even if we say that the fractured patient needs to be treated because they have a high risk of refracturing, only 20-25% of these patients commence therapy. So that means that we are still sitting with a bomb without really realizing that the patient in the next 9-18 months could fracture the other femur. And that is a very, very, very high risk that these patients have. So in order to prevent at least a second hip fracture, then new biomaterials have been invented. Biomaterials that you can put at the time of the surgery of the first hip fracture on the contralateral femur. And that's a biomaterial that in time becomes bone. So during the first 6 months is transformed. In 1 year, it's certainly now becoming bone, and now is a true bone, much stronger, that allows the patients to rebuild up resistance to fracture. The International Osteoporosis Foundation is the organization that really has been putting a central osteoporosis in their mission. So the vision, obviously, is the one of organizing in all the countries in the world, in any hospital, the one system that is responding to the need of prevention of fracture. And the system is called Fracture Liaison Service. And the Fracture Liaison Service is when you have a patient that now enters a system after the fracture and is not abandoned, because today fractured patients are still left out home without any indication, no indication for nutrition, no indication on future fracture risk, not densitometry done. They're totally abandoned. But fracturing is a big problem, costly, and mostly it causes a lot of disability in patients. So we need to build up these fracture liaison services. And the hero within the fracture liaison service is the nurse, because it's the nurse that is taking the contact between the ER, the orthopedic surgery, the rehabilitation doctor, the bone doctor to prescribe the drugs, and then the follow-up of the patient through the GPs. It's exactly a nurse that is going to become central in the FLS. The Capture the Fracture logo, that is a flagship of the International Osteoporosis Foundation, was launched in 2012. This was planned to facilitate the initiation of post-fracture care coordination program, such as the fracture liaison services. And the governance of this, I'm chairing this since 1 year within IOF. We are governing now over 1,000 FLS in the world, from Far East to Europe, Africa, South America. So that's an area of great interest. And we always encourage the fracture liaison services around the world to apply and to become part of this large family in order to learn also from the others. The very good experience that, for instance, Japan did in the past couple of years have been an example and set up the standards. We really want no fragile bones. And that was the campaign of 2024 of IOF, no more fragile bones. Osteoporosis is important, need to be taken care. We have drugs that prevent fracture. Hip fracture is the most preventable event in the elderly population, more than any other type of chronic event in the life of a person. And we don't do enough, because we are diagnosing about 20% of the people that have the rights to be evaluated. We are curing 20% of the very severely fractured patients like the hip fractures. So we are not doing enough. And nurses, as I said, are going to be central in these future developments. Thank you very much for your attention.